The WHO called for more research in the field of the new antibiotic, but many companies are not more interested in it. Which is the solution?
Sure. So I think that the WHO and many government bodies, they realize the challenges with antimicrobial resistance. And they're calling upon these public and private partnerships to help develop new antimicrobials. The challenge, though, as we talked about today, is that as these new antimicrobials get integrated into our clinical practices, oftentimes people are thinking this is an expensive antibiotic, but they don't really understand the value of the antibiotic. They're focusing on drug acquisition costs, not necessarily the potential improvement in clinical and microbiologic outcome, or the potential to reduce the overall duration of hospitalization, which is generally the driver. So we have to change our philosophy about the value proposition of the new antibiotics. And if we don't change the value, and we don't begin to integrate these new tools into clinical practice, then why should the pharma companies develop new medicines? It certainly won't pay for the development costs, and the tool will be useless in the context of patient care.
So the point is not only research and approval, but also the use of new antibiotics in the clinical practice.
You know, we've had 15 new antibiotics approved in the US since 2010. And both the US FDA as well as the European Medicines Agency, they've realized that these new medicines are increasingly needed. And I think they've tried to do good things. They've tried to help develop studies that are going to be suitable for approval. They are using more streamlined approaches for approval in special patient populations. So I think the medicines are getting approved. But the challenge is that once those medicines get approved, to figure out how to integrate them into clinical practice so the benefits of the new medicines offset the cost of the new medicines relative to quality and care.
And how much they do reduce the mortality?
So, you know, it depends on what study you look at, and many of these studies are not randomized controlled trials with very large populations. But I think it's fair to say that when you look at carbapenemase producing Enterobacteriaceae, and you look at the previous conventional trials where colistin is essentially the backbone with tigecycline or carbapenem or fosfomycin, mortality rates somewhere in the range of 40 to 60%. When you look at the new beta-lactam, beta-lactamase inhibitors, and you look at ceftazidime avibactam, meropenem avibactam, and increasingly, I think, with imipenem, relebactam, you will see those overall mortality rates somewhere in the low teens. And that's a very big difference relative to the overall clinical cure and microbiologic efficacy.
So you say that we already have a super antibiotic for superbugs, but we don't use them.
Correct. So again, the challenge is getting these medicines to the right patients and getting them to the patients early. And what has prevented much of that globally is the cost of the new medicine. So again, we have to try to define who's the right patient and drive early appropriate therapy.